So can you see this slide?
Yes, Macha. Yeah.
Later I will send the presentation if you guys want that. The thing is,
Okay.
usually these topics will be asked in the MCQ. There are each and every year there are 2 or 3 MCQ. So I will discuss the MCQ together, including all the topics tomorrow. So we will see how to approach, how to actually the theory of this emergency. So the main one is the sorry. I think you can see now, ne? This is the most commonly asked and the common emergency we have to know is the postpartum hemorrhage. That is the most commonly asked topic to be asked questions in the paper. So first we will look at the PPH. So we have to know the definitions. I think for the exam purpose, we don't need to remember these definition because they won't ask. Sometime in the longest discussion, at the end, they may ask some question regarding the definitions or something regarding the emergency at the end, if the discussion goes on up to that level. So commonly, otherwise you won't, we don't need these kind of definitions to answer the question unless there is a SEQ question. So sometimes you may be asked in the short essays. So that is the only thing, the place we need the definition. Otherwise, with the knowledge of the emergency, we can answer all the questions. So just look at definition. Sometime you might have studied a different definition. This is the new definition, updated one. So what they mean is any amount of blood. There is no particular amount of blood they are mentioning. Any amount of blood that is enough to cause the physiological changes like increase in heart rate, reduction in the blood pressure, and threatening to life of the woman. So they don't give a cutoff value of the amount of the blood loss. So any amount of blood, because the blood volume differs from person to person according to the body weights. That's what they brought up this new definition. So we know there are several causes regarding the postpartum hemorrhage. And if you take the postpartum hemorrhage, that is the most common direct maternal death. I think you know, everyone knows about the definition of direct maternal death, indirect. So there are 4, I think, topics regarding the maternal death. So you have to know that. So out of that, this is the common cause of direct maternal death that we have to know. Sometimes it may be asked in the MCQ. Then there's way of classification. This is the older one. How to classify a postpartum hemorrhage. So broadly, we can classify into primary, secondary. Primary mean, but they mean the PPH, postpartum hemorrhage that occurs within the 24 hours of delivery. Soon after the delivery, that occurs, that is a primary one. Secondary one mean after 24 hours up to 2 weeks. So that is secondary. If you take the primary one, usually in the ward, we used to see this kind of PPH, primary PPH. Secondary PPH, usually due to the infection, endometritis, due to some procedure we do, so or the abnormal removal of the placenta, so the retained placenta within the uterus get infected. So those are the common cause for the secondary PPH. Primary PPH is some issues regarding the tone, trauma, that thrombin kind of thing. We will look at it later. So again, the primary PPH can be classified minor and major according to the amount of the blood. So just have an overall idea. No need to remember hardly, just have an idea. So less than 1000 is a minor one, more than 1000 is a major one. Again, the major is classified into 3, intermediate, severe, massive. Just have an idea on the amount of the blood. Okay. Then this is very, very important. What are the causes of the primary PPH, postpartum hemorrhage? So we know, we call it 40, stone, tissue, trauma, thrombin. We have to know this. And out of the 40, tone is the most common. Within the tone, uterine atony mean uterine fail to contract after the delivery of the baby. Usually after the delivery of the baby, uterine contract and goes back to the normal size and the position. So if it doesn't occurs when the uterine fail to contract, there will be a huge amount of bleeding. The contraction itself prevents the bleeding, but when there is when there is absence of the uterine contraction, there will be a huge amount of bleeding. So that is the most common cause that we have to remember that. Other than that, there are several causes I have categorized that. Just go through the causes. No need to remember everything. Just have an idea under each topic what can be the causes. So up to now, okay? I take it as yes. Okay.
Yeah, Macha, yeah, sure.
Then how to manage? This is how to prevent the PPH. How to manage them? How to prevent the PPH? Postpartum hemorrhage should be prevented as much as possible. So before delivery, we have to make sure some things to prevent the PPH. The first one is treating the anemia. So before going for the delivery, we have to make sure that the hemoglobin level at least should be more than 10. That is one thing. And minimize the blood loss during the delivery. So we have to as much as possible reduce the time of the birth. Those kind of things we can do to reduce the blood loss. Active management of third stage of labor, that also minimize the blood loss during delivery. So what are the things we are doing at in the active management of third stage of labor? You would have known that. So just for the recall, I have mentioned here. We know after the delivery of the anterior shoulder, we are administrating the oxytocin. If it IV, we are giving the 5 international units of oxytocin. Otherwise, we can go for IM injection also. That is 10 international units. And control contraction. Control contraction means we know while pulling the placenta out using the cord, we have to use the counter pressure on the uterus. We have to push the uterus through the abdomen upwards, and we have to pull the cord. Otherwise, uterus will be inverted. So that will cause for severe bleeding. So that is one method. And deferred cord clamping means the name is same for the delayed cord clamping. We have studied usually the cord clamping is done after 2 minutes of the delivery. So the new name for the delayed cord clamping is a deferred cord clamping. That's what I have mentioned, that we have to avoid in some circumstances. So if we expect PPH, we have to avoid that. We have to do the immediate cord clamping, and we have to do the other stuff. So deferred cord clamping will give some time for the bleeding. So we have to avoid that in certain circumstances if we expect PPH, a patient. And usually we would have seen after the cesarean section, we can administer IV tranexamic acid. That will also prevent bleeding. So while doing the cesarean section, if we observe there is a significant amount of bleeding, we can use IV tranexamic acid. Usually we are using 1 gram. That is IV. So that is also we can use if it's needed only, not in every patient, if it's needed only. So how to manage the PPH? So that is to prevent. Now, how are we going to manage the PPH? Management of PPH, we have to know in and out, because in each and every sentence there will be MCQ or SBR. So we have to know what is the next step, what can be done. So kind of questions, there will be a lot of questions. So we can look at tomorrow. So just each and every sentence we have to know. So manage PPH, when we see a patient or a mother with a PPH, first we have to identify the severity according to the classification. First severity, because according to the severity, we are going to approach the patient. This is the severity, minor or major. Because for the minor PPH, we are not going to do acute, there is also emergency, but not a very rapid management we are not going to do. If there is a minor PPH, first we are going to take the history, and we are going to do the proper examination, including the vaginal examination. Like that kind of approach we are going to do if there is a minor PPH. But if there's a major PPH, we have to approach it as a emergency, the acute severe emergency. So we have to go for the ABC approach. So minor PPH, just keep it in mind that we are going through the history examination and we are going to manage the patient. But major PPH, we are going to approach the patient as a ABC. Airway, breathing, circulation, that kind of approach. I didn't mention each and everything A, B, C because we would have studied in somewhere. So sometimes there will be a huge amount of the blood loss. So sometimes we may need massive transfusion protocol. So there is a cutoff value. I think 50% of the blood loss within 24 hours or something. So that is what we call the massive blood loss, massive bleed. Then we have to start the massive transfusion protocol. Mean we have to inform the blood bank that this much amount of blood loss is there. So we are going to activate massive transfusion protocol. So they will be continuously distributing the ward or the setting the blood packs. So that is nothing else. So they will quickly give the blood packs. That is because they won't anyway ask each and every step in the long case discussion. In the SEQ, sometime they may ask, they can give a scenario and they can ask how to manage this patient. So we have to go step by step. The first one, call for help. Then ABC approach. Under ABC approach, you have to mention each and everything. Airway, how to think, how to approach, breathing. Check for the breathing, the oxygen supplementation, getting the IV cannula, do the blood test, and grouping and DT. So all the stuffs under ABC approach we have to write if there's a question. So just I have mentioned one sentence. And massive transfusion protocol, just mention if needed only we can activate. So there we use the Rotem criteria. So that up to that level we don't need massive transfusion protocol if needed. That's enough. Then this is for the stabilization of the patient. We have to first stabilize the patient according to the clinical vital parameters: heart rate, respiratory rate, blood pressure, capillary refilling time. We are looking at, and we are resuscitating the patient, and we have to make sure that the patient is stable. Then after stabilizing the patient, we have to look for the cause for the PPH, because we have categorized there are several causes for the PPH. Though the common cause is the uterine atony, we have to look for the actual cause. So first one, we are going to palpate the uterus because that is the most common cause, uterus atony. So when we after the delivery, when we palpate, we have to see a contracted hard uterus. Hard uterus should be there. But if there is a uterine atony, the uterus won't be that much hard. It will be, feel like a soft. So sometimes it may be the sole cause. Sometimes there may be dual pathology. We don't know. So if we find that the uterus is not contracted and the uterine atony is a cause, also we have to look for other cause. At the same time, we have to start managing the uterine atony. That's how we have to approach the patient. We are feeling the uterus is not contracted, so we know that is one of the cause, but we don't know whether there is any other cause going along with the uterine atony. So we have to start the managing for the uterine atony, and also we have to look for other causes. How to look for other causes? First, we have to do the simple Sims speculum examination. We have to look the vaginal canal with the Sims speculum, and we have to look for any tears or trauma in the cervical canal. I think I don't need to explain the Sims speculum, so everyone knows that. So we have to look for the vaginal canal for the trauma, for any tears. Then after doing the examination with the Sims speculum, what we have to do is we have to do the Sims speculum examination using the green Armitage forceps. So there's a way of visualizing the cervical canal with the green Armitage forceps. I will give an overall idea. How is this? If this is a cervical canal, because soon after the delivery, the cervical canal will be opened anyway, so we can see a round space at the cervical canal. So how are we going to approach the patient is, we are going to put the Sims, the green Armitage forceps at 12 o'clock. Then we are going to put next forceps, the green armitage forceps at 3 o'clock. Then when we put the forceps, then we can have enough visualizing space. So with the forceps, we can visualize this space. Then we have to bring this 12 o'clock forceps to 6 o'clock, and we have to visualize this space. Likewise, in a clockwise, we have to inspect all 30-60 degrees. That's how we are doing the green armitage forceps. After that, at the same time, we have to examination the placenta. We have to know the placenta should be completed one. So every cotyledons, we have to check whether the placenta is completed or whether there is something is missing. So then we have to do the manual examination, and we have to look for that something within the uterus. That is the last one, looks for clots manually. So then we have to put manually our hand, and we have to remove the clots if no cause is found. But anyway, the common cause is uterine atony. So mostly the case, or if they are asking the question, mostly regarding the uterine atony. Rarely other causes will be asked in the question. Okay. Okay. Then how to manage the uterine atony? That is the most important thing, and we have to know. Not other causes. How to approach management uterine atony. First, we will see how to approach this. First, we have to do the general fundal massage. We have to know, we have to keep the hand in the abdomen, and we have to massage the fundus. Usually, even if there is no PPH, soon after the delivery, the nurse staffs usually give the fundal massage to make the uterus contracted. So fundal massage is the first thing. Then we have to make sure that empty the bladder, because if the bladder is full, it will be pushing the pressure on the uterus, that will cause for further bleeding. That will prevent the uterus from contracting. So first we have to make sure they empty the bladder. So we can put a catheter and we can empty the bladder. Then even after it is failed, then we are going for the oxytocin IV 5 international unit bolus. Quick injection we have to give. This is not included in the active management of third stage of labor. That is other 5 international unit of oxytocin. So second time we are repeating this oxytocin 5 international unit IV bolus. We are giving that. Then we are looking for the response. If still bleeding, the next step is ergometry. 0.5 milligram IV or IM injection. Either we can give, whatever is available. Usually the IV cannula is there, so we can give the IV. We have to know, you would have studied, ergometry is contraindicated in patients with heart disease and hypertension. So in those patients, we can't use the ergometry, that is contraindicated. After that, even if the ergometry is also not working, then we have to go for the oxytocin infusion. How to prepare the infusion set is, we are taking 8 bottles of oxytocin, each contain 5 international units. So total of 40 international units of oxytocin. We are mixing within the 500 ml of normal saline, 1 bottle of normal saline, and we are giving it as an infusion for 4 hours. So 125 ml per hour. That is a rate. Each and everything I'm telling can be asked in the question. So just keep in mind. So this is the amount of unit we are using. This is the amount of normal saline. The rate is 125 milliliter per hour. You can calculate that. 500 ml per 4 hours. So 1 hour, 125. The next thing is, even if at the same time the oxytocin is started, we will giving the next step, carboprost. Carboprost is a prostaglandin E2 agonist. They can ask that also. What kind of what is the mode of action of carboprost? Prostaglandin E2 agonist. So we are giving 0.25 milligram intramural. We are giving the injection to the uterus. That is carboprost. 0.25 milligram. IM means intramural. We are giving the injection into the uterus. So we can give maximum of 8 injection at 15 minutes interval. Sometimes mostly they won't ask this. Just you can skip that. So just remember carboprost, that is prostaglandin E2 agonist, and we can give the intramural injection. The next step is Misoprostol. Misoprostol can be given in two ways. One is IM injection, or we can give the per rectal. So if you are giving for the IM injection, we can use 800 microgram. If we are going for the per rectal, we can use 1000 microgram. We can't use intravaginal. IV can't be used. That we have to know, because there is a huge amount of bleeding through the vagina, so we can use the IV, intravaginal. So we can use the PR or IM. So I have typed that. Then the next option is the tranexamic acid, IV tranexamic acid, 1 gram. It should be the order how to approach a patient with a PPH. These are the medical management we are using at the beginning of the management. Then after all this medical management, we are going for the surgical method. Manually, what can we do? First one is a bimanual compression. You would have seen the photos how to do a bimanual compression. We have to put our thumb into the uterus, and we have to compress on the by using the other hand on the abdomen. We have to give the pressure on the uterus. With the pressure, sometimes the bleeding may stop. And also, if the bimanual compression works, we know the following steps also will work properly, because all these mechanism we have used, bimanual compression, balloon tamponade, hematostatic sutures, all works using the pressure. In every step we are using the pressure. So we know if the bimanual compression works, the following steps also will work. So that is a good indicator if the bimanual compression works. So that we have to know. After the bimanual compression, we can go for the balloon tamponade. You would have seen the Bakri catheter. That is the ideal one. If the Bakri is not available, then we can go for the quantum catheter. But anyway, Bakri catheter is the ideal one. Then, even after the balloon tamponade, we are going for the hemostatic suture. We will be doing the laparotomy, and we are going for the hemostatic. If the cesarean section, then we will open the wound, and we are going for the hemostatic suture. Just remember all these sutures, because they will ask in the MCQ, what are the hemostatic sutures we can use for the management of PPH? B-Lynch, modified Heyman's, and box suture. Those are the sutures. That's more than enough. If you want more, if you know more details, just keep in mind. But if you know what are the sutures we can use, that is more than enough. Then the devascularization. So that is kind of last part. Even if the hemostatic suture doesn't work, then we are going for the devascularization. We are going to cut off the blood supply to the uterus. First, we are stopping. We are putting the clamp on the uterine artery bilaterally. Usually, the ascending branch of the uterine artery. We are putting the clamp and see whether the bleeding stops. Even if it doesn't work, then we are putting the clamp on the internal iliac artery, the main branch. So on the bilaterally, we will be putting the internal iliac artery clamp to stop the blood supply to the uterus. Then also radiologically, we can use the uterine artery embolism. That is also a method. Sometimes we also can use the clamping of the aorta as well. We can use the descending aorta, abdominal aorta also, or at the level of the pelvis, we can use the clamping of the aorta as well. But we can't do the clamping for the long period of time, because it will cause ischemia to the limbs. So that is not possible for the certain period of time. So we can use it for the small period of time. Just keep it remember. Then the last option, postpartum hysterectomy. There's no other way to stop. Then we are going to remove the total uterus. So that is how to manage. Then the complication, we know in each and every bleeding problems, there will be the complication like shock, end organ failure, DIC, and sometimes death, maternal death. Then this is a special one for the pregnancy, Sheehan syndrome. We know what is Sheehan syndrome. Due to the significant bleeding at the time of postpartum period, there will be ischemia to the pituitary. So there will be a deficiency of the pituitary hormones. That is called the Sheehan syndrome. I hope everyone knows that. So this is one special complication regarding the PPH, and also sometimes they may ask complication. There may be some complication which I have not mentioned, so you can work out on that. So just a few sentences regarding the secondary PPH. So what we have studied everything about the primary PPH. Secondary PPH, I have already told that the common cause is the endometritis infection. The common infection is endometritis, infection of the uterus. That is mainly due to the maneuvers that we are doing, putting our hand into the uterus, so doing the manual removal of the clots. So we are using a lot of maneuvers. So at the time of the maneuvers, it can get infected, and also the infection usually occurs after 24 hours, up to 2 weeks. How are we going to manage this? First, we have to get the sample to see the organism. So we will be getting endocervical swab and high vaginal swab. After taking the swab, then we will be starting the antibiotics. The antibiotics is gentamicin or clindamycin. I think 1 year they have asked this MCQ as well. What is the antibiotics can be used? I think they have given the answer of gentamicin. So you have to know clindamycin also can be used. So if there is abscess or some kind of foreign bodies, then we have to go for the evacuations of these foreign bodies. So that is all regarding the PPH. If anyone want to ask any question, any doubt?
No, understood that.
Understood. Then we can move to the next one.
Masang, if you don't mind, can you send the PDFs?
Yeah, I will send the PDF of all my documents, because yesterday only I have finished my documents. I couldn't get a time to do that. I will today itself I will send it everything.
Okay.
Sorry. The next one, we will be looking at the cord collapse. I will, because I haven't prepared the presentation for the antepartum hemorrhage at the during the pregnancy, so I will do tomorrow. So this is regarding the cord collapse. So we know this is not that much common one, but anyway, it can occur. Cord collapse. So we have to just for your knowledge, this is the definition: descent of the cord through the cervix alongside or beyond the presenting part of the after rupture of membrane. Because for the cord collapse to occur, we have to know that there should be a rupture of membrane spontaneously or artificially. We should have done the rupture of membrane. After that only the cord will become out. So the cord should pass through the presenting part and coming out. Sometimes it may be within the cervical canal, or sometimes it may come outside. So it can be anywhere, but it should come along with the presenting part. So that presenting part is the one which is going to compress it on the pelvis or somewhere, causing every problem. So that is the definition. So what is happening in the cord collapse? Why there is a problem with the cord collapse? When there is a cord collapse, as I mentioned earlier, the presenting part can compress the cord, and that can reduce the blood supply to the fetus. That can cause fetal distress. That is one thing. The second one, if the cord come out, what happens is the cord is exposed to the external environment. So external environment is colder than the internal environment. So due to that coldness, there can be cord spasm. So cord get contracted. So that also can prevent the blood supply to the fetus. This is the two physiological mechanism which can cause fetal distress in cord compression, cord prolapse. So we have to have an idea on that. The risk factors, we have to know each and everything. So you can work it out. So we have to think what are the circumstances can lead to the cord coming out of the presenting part. Presenting part means it can be anything. So it can be breech, it can be leg, it can be hand, whatever. Malpresentation is the common. Why? If there's a head, just think, if there's a head is the most largest part. So it will be fitting into the pelvis. So if the head is the presenting part, it won't allow other than any other parts coming through the vaginal canal. It will prevent everything and keep it everything within the uterus. So if the presentation is a head presentation, cephalic presentation, the rarely can occur. It can occur, but rare chance. If there's a malpresentation, like if there's a leg or hand is there, we know that there's enough space for the cord to come out when we do the rupture of membrane. So malpresentation is one. Multiple pregnancy, we have to know in the multiple pregnancy, we can't expect the child to be in the cephalic presentation. Each and every child will be in different position, different presentation. So there will be enough space. Multiparity. In multiparity mother, usually the uterus get laxed and there will be a huge abdominal cavity. So there also there's enough space. Then small fetus. Again, if there's a fetus is small, the free space is high. Then prom, P-prom, if you do, if there is a rupture of membrane, there is a risk of cord collapse. So prom, P-prom. Polyhydramnios, again, there is a huge amount of fluid. So it increases the space. Low-lying placenta. The problem with the low-lying placenta is the presentation will be something else, not the cephalic. The chance of malpresentation is high in the low-lying placenta. So there is high risk. Then whatever the manipulation we are doing, ECV, external cephalic version, internal podalic version, breech extraction, rupture of membrane, any manipulation that we are doing artificially can cause this complication. Then how to prevent that? First, we have to identify the risk factors. Any risk factors is there, we have to look for that. Then we have to do the proper method to do the artificial rupture of membrane. When we are doing the ARM, we have to do in a proper way. After doing the rupture, we have to make sure that we are releasing the fluid more slowly. As much as possible, slowly we have to do the releasing of fluid. Because when we do the rupture of membrane, we suddenly if we release all the fluid, then the high chance of cord coming out is there. So we have to do the rupture of membrane and we have to make sure that we are releasing the fluid slowly. We would have seen in the ward. Usually they are literally they are getting the fluid out. Not that much at once. Then diagnosis. So if there's a cord collapse, we have to diagnose. Usually we can diagnose with a CTG change. There will be several CTG changes. The variability will be reduced and there will be a fetal tachycardia. So those kind of symptoms, signs will be there with the deceleration, variable deceleration. So that is one thing. Sometimes we can see the cord outside. If there is a huge cord collapse, overt cord collapse, the cord will be outside from the introitus. So not introitus. So we can see the cord. Cord will be reddish blue in color. Sometimes the cord will not be seen outside. It will be in the vaginal canal. So when we do the vaginal examination, we can see the pulsation of the cord. So that is other thing. That is how to diagnose that. But if you have a suspiciousness of the cord collapse, we should not do repeated vaginal examination because whenever we touch the cord can get spasm because our hand is so cold compared to the body temperature. So we should avoid repeated vaginal examination. So that is we have to make sure. But vaginal examination is all one method to diagnose this condition. Then management. First we have to do the call for help. Then we have to do the vaginal examination, not to palpate the cord because the diagnosis has been made. This is to decide how are we going to manage this patient. Do the vaginal examination and look for the cervical, do the proper cervical examination and look for the feasibility of the delivery. When we are doing the vaginal examination, the cervix is fully dilated and the FSCM is 100%, then we know that we can go for immediate vaginal delivery. We can fasten the delivery with the instrumental delivery. So if the cervix is fully dilated, then we can go for the instrumental delivery. Never ever we can do we have to do the forceps delivery, but we can't do I couldn't remember the name. We can do the suction.
Vacuum delivery we cannot do.
Yes. We can't do the vacuum visit. I couldn't get the name. Vacuum delivery we can't do. That is contraindicated. Because we have to have a space to put a vacuum. So if you put this vacuum into the cord, that is the end of the baby. So only delivery we can do vaginal is the forceps delivery. So we have to do the vaginal examination and we have to see the feasibility of the cervix. If it's there, then we can go for forceps delivery. If there is something problem with the instrumental delivery or the cervix is not fully dilated, then only option is emergency C-section. Category 1. No any other option. We have to immediately inform the theatre and we have to bring the patient to the theatre and we have to get the child out. But when we are after diagnosis the cord prolapse, also we have to do ultrasound scan to see the viability of the fetus. Because no need to go for the emergency C-section or the forceps delivery if the child is already dead. So that is also we have to do. We have to do the ultrasound scan abdomen and we have to see the viability of the fetus. If this fetus is viable only, then we are going for this management. If the fetus is not viable, then we will wait and we will be doing the normal vaginal delivery. We can induce whatever we can do because the child is already dead. Until doing this C-section, emergency C-section, what are we going to do? That is the thing. It will take 10 to 15 minutes to bring the mother to the theatre and put a cut on incision on the abdomen. Until then, what are we going to do? Make sure we are not handling the cord. That's what I already told. Do not do the repeated vaginal examination. That should be contraindicated. Don't handle the cord. But sometimes the cord may be well outside from the introitus. So we can see the cord. Then what are we going to do? Because it is exposed to the external environment. We should prevent that also. For that, what we can do, we can wrap the cord with the moist cotton bandage. Then we can, after wrapping that, we can put the cord into the vagina. Just pulling some distance and putting it into the vagina. That is the only thing we can do. If the uterus has started to contract, we can use the tocolytics. And after that, we have to put the mother in the knee chest position and inform the theatre, PHO, anesthetics, and we have to immediately bring the mother to the theatre in the knee chest position. No any other position. Until the delivery, we have to keep the mother in the knee chest position, and also we have to put our thumb into the vaginal canal and we have to pull the presenting part upwards towards the uterus. Until the surgeon put the cut, we should not get the hand from the vaginal canal. That is the ideal one. So this is we have to do. But sometimes, even when we bring the mother to the theatre, sometimes there may be other surgery. So we will be, we should be waiting for other 10 minutes. Then for that 10 minutes, what are we going to do? That is where we are going to do the filling the bladder with 500 ml of normal saline. So we are bringing the mother to the theatre. There is other surgeries gone. It will take 10 minutes more. Then until the 10 minutes, we are going to fill the bladder with 500 ml of normal saline. Until that, no need. I think you would have got what I told.
Yeah, Maja. Yeah.
So if the POI is less than 24 weeks, we know the child is not viable anyway. So that is expectant management. We can't do anything. We are not going to do any emergency management. So we will be managing as usual. Okay.
Yeah, Golo. Yeah, got it.
I think that's all regarding the cord prolapse. We will move to the next one. Can you all see this slide?
Yes, Maja.
So these are the PPH is the somewhat the large topic. Other topics are smaller one. So you can study easily, but each and every sentence just keep it in remember. They will sentence by sentence they can make questions. That is a more the important thing regarding the emergency part. What is shoulder dystocia? Again, the same some kind of definition there. Vaginal cephalic delivery that need additional obstetric maneuver to deliver the shoulder, and the genital traction is failed. Because when we are doing the delivery of the baby, after the delivery of the head, we are just putting the genital traction to deliver the shoulder and rest of the part. So, but in the shoulder dystocia, we can't do that. To deliver the head, we need additional maneuvers. It may be manual or surgical methods we need to do. That's what they have mentioned in the definition. The most common one is the anterior shoulder dystocia. Usually the anterior shoulder gets struck against the pubic symphysis. That is the most common one. Less common one, the posterior shoulder against the sacrum of the pelvis. The most common one we have to know, anterior shoulder against the pubic symphysis. This is the incidence. Just have an idea. No need to remember. So what are the risk factors regarding the shoulder dystocia? There are diabetic mother and the macroscopic baby. Usually, if the baby is more than 4 kilograms, we are not going for the vaginal delivery. But if the mother is a diabetic mother, if the weight of the baby is more than 3.5 kilograms, we are not going for the vaginal delivery. Because when mother is a diabetic, we know the child gets more glucose from the mother due to this diabetes condition. So whatever the extra glucose the baby is getting, some amount of the glucose will be get deposited in the shoulder region. So usually in a macroscopic baby of the diabetic mother, the shoulder get broadened. So there is high risk of shoulder dystocia if the baby's macroscopia weight is more than 3.5 kilograms for the diabetic mother. Just keep in remember. Other indication, other risk factors, just go through the list. Any kind of maneuvers or induction of labor, any augmentation, whatever we do, everything can cause shoulder dystocia. Just go through the list, nothing to explain. How to diagnose the shoulder dystocia is very important. The most commonly asked one is a turtleneck sign. Sometimes they may ask in the SEQ as well. Turtleneck sign. The head will be coming out and going inside. Coming out and going inside. With a contraction of the uterus, the head will come out. When the uterus relaxes, the shoulder won't leave the rest of the body to go out. So the head will be go inside again. So that kind of turtleneck movement will be there. So other thing, difficult in delivery of the face and chin, because when the head pass through the pelvic ring, it won't come out. So we will be seeing a part of the face, but we can get up to the chin. So it's so difficult. And failed restitution due to the baby's gets struck in the pelvic brim, we can't turn the baby. The restitutional movement won't happen. The turning won't happen. That is a failed restitution. We have to have an idea how to diagnose SC, shoulder dystocia. Then the complication. So there are several complications. I have classified in the maternal and the fetal complication. So if you go through this, you can work out actually. No need to remember this unless they ask in the SEQ, but rarely they will ask in the SEQ. So otherwise you can work out. So just go through this. I will also give the presentation today itself. How to manage the shoulder dystocia? This is what you have to know, nothing else. If you know this flow chart, that is more than enough. As usual, call for help. And also, once we call for help, we have to tell the mother not to push more, because at the time of the this problem, usually mother in a position urge to push. So we have to ask the mother not to push. And also, if there's oxytocin oxytocin infusion is going on, we have to stop the oxytocin. Those two things we have to do. Then we have to get the mother to the edge of the bed, because that is more get a lot of space for us to do all the maneuvers. Then the first thing we are going to do is the Mac Roberts maneuver. We have to know each and every step here in an order. First thing we are doing is the Mac Roberts maneuver. That is, ask the mother to flex the hip joint as much as possible. So it should be parallel to her abdomen. So we can see this. This is how she has to flex. So what happens is, when she do this movement, the anterior posterior diameter increases. So there will be some space for the delivery of the shoulder. So that's why we are doing this. Usually, we would have seen in our labor ward, even for the normal delivery, the nurses are doing this maneuver to the mothers, without knowing that this is a maneuver. Actually, this is the Roberts maneuver. After giving this maneuver, we have to put a pressure on the suprapubic region, just like in a bee. She's putting a pressure on the suprapubic region. And also, at the time of the pressure, we can just try to do the genital traction. Just we can try to nicely pull the baby. If it's not coming, we can't do anything. Then we have to consider the episiotomy, or if already the episiotomy is done, we can extend the length of the episiotomy. We can do that. After that, we can do the genital traction. We can see whether it's coming, it's not coming. Then we have to decide what are we going to do, because there are two options: delivery of the posterior arm or internal rotational maneuver. We can do either one. Not both. We can try either one according to our experience. So no need to know how. Can you all hear me? Hello?
Yes, Master. Can hear.
No problem, because
No
there's a
problem.
message that connection is unstable. Okay. So you no need to, for the exam purpose only I'm telling, no need to know how to do the maneuvers. Just remember that out of two, you can do either one. After trying the one, you can go for the next one. You are trying first, initially you are trying the posterior arm delivery. If it fails, then you can go for internal rotational maneuver. At the time, we have to make sure the obstetrician is available in the for the management, because the next step of management we can't do. If all fails, then we have the next step is the put the patient on the all four position. All four position means like a cow. Put the mother in all four position like a cow, and we can do all the maneuvers again. We can do the repeated of all these steps again to see whether it's working. Then if it doesn't work, then we have to go for the last option, clidotomy, mean breaking the clavicle of the baby. Because when we fracture the clavicle, the shoulder will come towards closer, so there will be shortened. There will be a length of the shoulder will be shortened, so we can deliver. That is clidotomy. Symphysiotomy means we are putting incision on the pubic symphysis of the mother, so it will give some space. Or Zavanelli maneuver, what we are doing is we are turning the baby backward and sending the baby into the uterus, and we are bringing the mother to for the emergency C-section. That is the Zavanelli maneuver. So this is the flow chart we have to know to answer the questions regarding the cord prolapse. Shoulder dystocia.
Machan,
Yeah.
if it is asked in the MCQ, so according to the order, it is like the emergency C-section is below claviculotomy and symphysiotomy.
Now the problem is, Majan, nowadays we are not going for the clidotomy or symphysiotomy, because that is a severe trauma to the baby. So what we are doing, Javanelli manual is the one we are directly doing after trying the all position.
Yeah.
But
Okay.
other problem is when we are deciding to do the Javanelli maneuver, the baby would have died already. That's the main issue with this problem, because what they are telling is, I think I would have mentioned. What they are telling is, we have to do all this maneuver and we have to try to deliver the baby within 30 minutes or something. So call for help, macrobus, suprapubic, and each and everything we are doing, it will take a lot of time. So at the time, at the point when we are deciding for the Javanelli maneuver, the 30 minutes would have gone, the child would have died. But anyway, we can try. There's a time, clidotomy, symbiotomy. Then the postpartum management. So after that, what we have to do is we have to do the active management of the stage of labor. That's the thing we have to do. I think that's all for shorter discussion. Any question?
No, Maja. Understood.
I think there are two more, because there are, and I want to tell, there are a lot of topics regarding emergency, like maternal sepsis and the amniotic fluid embolism, but don't get afraid because they won't ask questions regarding the amniotic fluid embolism. That is the most rare thing. So don't study each and everything. I will be doing the topics which are very important and commonly asked topics in the MCQ SEQ. So I think it is enough to study those topics, but that is your decision to study for the other topics like amniotic fluid embolism. But no need to waste the time on those small topics, because they won't ask anyway the questions regarding those topics. For the example, I am telling the amniotic fluid embolism, maternal sepsis, because maternal sepsis, when you if you know the management of sepsis, you can manage the questions regarding the sepsis as well here also. So no need to waste a lot of time on that. Next thing. So when is your next? What is the time that you're having the next class today? 6:30 or 7? Hello.
For me, Machan, I have only this.
Oh, you have only this name.
Yeah.
So then I think we can have the session on, because others are anyway listening to the recordings thing. Then we can have the session on tomorrow, because I would like to cover only two topics tomorrow. Then we can move to the MCQ.
Okay,
So
Machan.
shall we do tomorrow then?
Okay. I'm
Okay,
fine. Okay, Machan.
study well. All the best, huh?
Okay, thank you, Machan. Thank you
Okay,
very much.
we'll
Thank
meet
you.
tomorrow. Okay, bye. Good night.
Bye. Good night.